जी अस्सलाम वालेकुम एवरीवन। आज के इस शॉर्ट वीडियो क्लिप पे हम बात करेंगे कि हाउ टू अप्रोच टुवर्ड अ वेरी कॉमन केस सिनेरियो ऑफ हैविंग द पोस्टीरियर ओपन बाइट इन द अलाइनर पेशेंट. So one of the most important thing you need to consider in every aligner case is the aligner must be extending toward or up to the last standing tooth, or it must be covering the mesial marginal ridge of the terminal tooth. For example, if the 8 is present, the aligner must be covering up to the mesial marginal ridge of the 8, so it would avoid and control the supra-eruption of the tooth, because the aligners are worn for the 22 hours per day. So if the appliance is being used for 22 hours, there is a very highly likely chances that the terminal tooth will start supra-erupting if it is not nicely and properly recorded into the scans or in the impression. So the minimal criteria of acceptance of the scan is that the terminal tooth must be recorded, and if the mouth opening is limited, then at least the mesial or half of the 8th third molar or the terminal tooth must be recorded in the scan, so the aligner can be extended up to the mesial marginal ridge of the 8. For example, you see this very disastrous case. The patient went abroad and there's a lot of posterior open bite because of the supra-eruption of the third molar. The aligner was not extended up to the third molar, and definitely we have to extract third molar for the correction of the this posterior open bite. But this was the extreme condition. Obviously the patient do report when they start noticing the posterior open bite. So the first approach toward posterior open bite is noticing the extension, the distal extension of the aligner up to the terminal tooth. Then second most common cause of slight disclusion or the posterior open bite is as the appliance is worn for 22 hours, then you would be noticing some intrusion of the teeth because of the thickness of the aligners. So this is very common, and if the patient start reporting that the posterior teeth are not nicely occluding, then what you can do two things. One is you ask the patient to use the aligner for nocturnal wear. 10 to 12 hours of wearing would be enough to a mild relapse of the posterior teeth, so they erupt again and come back into the occlusion. The second thing you can do is the trimming of the aligner up to the distal side of the 3. Canine to canine, you will extend the aligners and let the and trim the aligner up to the distal of the 3 and let the posterior teeth supra-erupt again, and this posterior open bite will be handled, because for the low angle patient, for the patient who have the habit of chewing the aligners after wearing them, so you can control the mild intrusion of the teeth by the nocturnal wear of the aligners or trimming the aligners up to the distal of the canines, so the posterior teeth relapse and come into the occlusion again. The second cause is the premature anterior contact. Premature anterior contact when the aligner is correcting the overjet. So while correcting the overjet, there is a quite likely possibility that the upper teeth will start hitting the lower teeth. So because of the anterior tight contact or the very less overjet, the posterior teeth will not be occluding nicely. This happens in the aligners when there is a track loss or the teeth are not properly intruding, especially when we are correcting the curvoscopy. You are correcting the curvoscopy, we are trying the intrusion of the lower incisors, and the lower incisors are not properly intruding. The lower incisors are not properly intruding, the upper teeth will start hitting it, and this may lead to the development of the very mild posterior open bite. So what you need to check? You need to check either this is the supra-eruption of any tooth, is it because of the intrusion of the posterior teeth because of the thickness of the aligner, is it because of the tight anterior contact that is causing the posterior teeth disclusion. That you can check with the help of the articulating paper, and that you can very nicely evaluate the overjet and overbite, especially the overbite, and you will see the intrusion of the lower teeth is on track or not. So this is very commonly happen when we have the attachment on the lower incisors and we are trying to intrude the lower incisors to correct the curvoscopy, and if it is not following, then the upper teeth start hitting the lower incisors, and this develop into the mild posterior open bite. Another cause is the lack of space in the aligner. You know, the teeth, when they do not get any space to move, because it is the tooth are encircled on all the aspects closely, labially, lingually, in all aspects by the aligner. So if you do not perform the proper IPR, the only possibility is the intrusion tooth movement that is allowed in the aligners. So you need to check if the IPR is advised and prescribed in the mid of the arch, and if it is properly following or not. If it's not, the IPR is not properly performed, and because of the collision of the teeth, the logical consequence would be the intrusion of the teeth in the mid of the arch mean premolars area. So that you need to evaluate it. I rephrase it, recap it. First, you will check the extension of the distal terminal tooth. Then you will check if it is caused by the thickness of the aligner that is causing the intrusion. Then you will check anterior tight contact, and you will also see if there is any IPR in the mid of the arch that has been skipped or not properly performed, or if it is underperformed IPR. That is the most likely causes of the posterior open bite. There are other causing as well, but I have discussed the most likely causes of the posterior open bite in the aligner cases.